Probably number one is my kid. So regardless of who I am in the hospital, what I've done, what operation, what I've done in like the ICU, when I get home, I'm still just dada, right? So regardless of what I have to do in the hospital, when I get home, it's still, making him dinner, right? Getting him to bed, giving him a bath. And that kind of can flip your mindset that I'm so lucky to have him and the joy that he brings me and to our family, right? So it can create a whole different sense of purpose outside of the hospital. So that's been wonderful for me. In doing this job and knowing that, I think it would be something he'll be proud of is wonderful as well. Having a wife that understands has been, I couldn't think of something better. For her just to be able to talk, or if I don't want to talk, right? Just hanging out in the silence is fine.
Welcome to the Critical Chats podcast,
or as I'd like to call it, Crit Chat,
where we talk about the new and exciting developments in the critical care world and get to know the providers behind the medicine.
I am Sheila Billica, PA.
And I'm Katie Shakura, PA. We're your hosts, and we're with our producer, Sneha.
I'm also a PA.
3 PAs on a pod. Welcome back to the podcast, everyone. Today, we are excited to deep dive into the life of Level 1 trauma centers and a Level 1 trauma surgeon. We are fortunate to have some of the best trauma and general surgeons caring for our population here in Worcester, Massachusetts. We're joined by Dr. Michael Iannamorelli. Today, he works on the front lines of emergency and trauma care, treating patients on what is often the worst day of their lives. His work goes far beyond the operating room. It requires calmness under pressure, teamwork across disciplines, and a deep commitment to patient care when stakes couldn't be higher.
I've never actually had a long conversation with Dr. Iannamorelli, so I'm very excited. In this episode, we will talk about what it's really like to be a trauma surgeon, the intensity, the responsibility, and the moments that stay with you long after the shift ends. I'm sure there are many of those.
There are, yes.
Welcome.
Thank you so much for having me. I appreciate it.
Yeah.
And before we start, I just want to thank both of you for taking care of our trauma patients in 3 ICU. It's been a privilege to work with both of you, so thank you both very much.
It has been awesome. Unfortunately, Shayla's not really there during the day. She's a night shift girl, but I often get the chance to work with you, so it's been very fun.
Welcome, Dr. Iannamorelli.
Thank you guys so much for having me.
All right. So just first off, tell us about yourself. Where do you come from?
Yeah. So
where are you heading?
So I come from southwestern Pennsylvania, about an hour south of Pittsburgh. And then I trained in Massachusetts, met my wife, and then we ended up back here. And we've been here for now 2 years.
What made you decide to become a trauma surgeon?
Yeah. So So my father, he's a primary care doctor back home. And so I actually got to rotate with him when I was in medical school. And so I got to see what it was like for a doctor in a small town. We would have patients' families, patients come up to us and say, thank you, Dr. I. He's, I guess, the original Dr. I. So I always knew that I wanted to be in medicine. So I got to rotate with him, realized that outpatient primary care was not for me. Then I got to rotate with a true general surgeon, Dr. Mike Riley, who just retired. And it was just me as the medical student and him. And we would do everything from mastectomies, hernias, amputations. So we got to do everything. And I said, that's what I want to do. And that's what I want to do with my life. So then I decided to be a surgeon. And from there, when I did decide to be a surgeon, I cast the net quite broadly and said, hey, wherever I can get the best training is where I want to go. So that made me want to be a surgeon.
And so where did you do fellowship?
So I trained initially at Berkshire Medical Center in Western Massachusetts, and then I went to Virginia Commonwealth University in Richmond, Virginia for a combined trauma critical care fellowship.
That's awesome. And then he wound up right back here.
Right. So what's your schedule like?
So the schedule, yeah. So being a trauma surgeon, if you wanted a 9-to-5, it's not the career for you. If you wanted to have a day that's the same every single day, it's not the career for you. But if you wanted to be able to walk into the hospital and know that you have the skills and the ability to, genuinely save lives, this is the career for you. So we do work nights, weekends, holidays. But that's just kind of part of the gig. Nobody plans when there is going to be a trauma. Nobody plans to be in a car crash or have an accident happen. But we're here all the time to be able to treat them and take care of them.
Yeah, it's pretty cool. Like, the trauma surgeons, when they're in-house on call, they can be like napping or sleeping on the cot in their office to all of a sudden just in the OR. Like, it's that quick.
And they have to be present.
Yeah.
On at all times. That's awesome.
So what do you do outside of this?
Yeah. So when I'm not in the hospital, I have a wife. I have a 4-year-old. That keeps me very busy. I like to ski, so the New England area was great. I also do Brazilian Jiu-Jitsu, which I've been doing for about 8 months.
Very cool. Do you have a gi?
I do, in fact, have a gi, yeah.
So from gi to white coat to scrubs. I love that.
Wow.
We're all the types of coats. We're all of them.
So he's going to be like beating people up, doing jiu-jitsu.
Well, he's not beating people up.
Rolling around on the mat, and then he's going to be taking care of them in the OR.
And then replating them. Let's talk about that.
So are we talking like half rack or full rack?
So rib fractures are probably what we most commonly see in pretty much any trauma center. Whether it can be from falls, motorcycle accidents, or car crashes. So the older population, so anybody greater than the age of 65, 3 or more rib fractures confers about a 20 to 25% mortality. If you're younger, more rib fractures you have, the higher mortality. And usually they succumb to pneumonia or issues with their pulmonary mechanics. So at this hospital in the last year, we've developed a pretty well thought out algorithmic rib fixation program. It's something I did in residency and fellowship in my last job. But Dr. Dorfman, the medical director, got everybody trained up. We have the reps from Zimmer Biomet to make sure that we're all staying current with the most up-to-date data and most up-to-date techniques. So we're completing roughly 30 to 40 cases a year here now. And so we're on par to be, top 3 busiest rib fixation programs in New England. Yeah. So anecdotally, we have patients that, I just saw in clinic. It was an older gentleman that had a big fall, fractured 10 ribs. We fixed majority of them. He comes in with his wife. He's very appreciative. He can get back to what he does, what he likes to do. And overall, he's really satisfied with the procedure, with the operation. And I do think that it helped him get out of the hospital sooner and get back to what he likes sooner.
What's the ideal patient, the rib fracture patient?
Yeah, so the ideal patient. So out of all the literature out there, pretty much all the randomized trials and all the meta-analyses, if you look at them, patients with flail chests, so 3 or more consecutive broken ribs, fractured in 2 or more locations, not able to be weaned from the ventilator are the prime candidates, and that confers decreased ventilator days, decreased length of stay, decreased ICU days. So those are by far the patients that everybody can agree on. When you kind of get out of the flail chest patients, that's when you have to really create an algorithm and make it patient specific. But patients with 3 or more rib fractures have issues with pain, even though we do multimodal pain. Epidural, serratus anterior block, and they're having still issues with their pulmonary mechanics. Those are patients that could benefit from rib plating.
And is there a patient that we really shouldn't be rib plating?
Yeah, so the data is not really there yet for older patients, especially osteoporotic patients. Mm-hmm. So those are patients that we're not sure if there's a benefit yet. I do think, so being a trauma surgeon, so this is roughly my in my 4th year, and even in training, those were the patients that no one was really sure. But I anticipate kind of the next bastion of rib fixation or surgical stabilization of rib fractures. That'll be where the next, data set comes from, or older patients. Because those are, like I said previously, those are the patients that will develop that pneumonia, that will have issues being in the hospital. They will have issues, getting back to, their lives. So I think that'll be the next step, is seeing which patients can benefit, especially the older ones.
Is there a specific time frame that you want to be rib plating these folks? Like, from when they get into the trauma bay and then, say they're in the ICU, like when is that period?
Yeah, so within 72 hours is the best time frame to fix these patients. And the patient's done, within the 72-hour frame time. Decrease opioid use, decrease lengths of stay, overall pain scores are better, and they can get back to work and get back to the quality of life that they would like. So ideally, we try to do it within 72 hours here.
That's awesome. Yeah. So tell us about the surgery itself.
Yeah.
Go through it from the beginning to the end. Yeah, every detail.
So the surgery itself, so let's say a patient comes in with multiple rib fractures, and we usually fix ribs 4 through 9 or 10. So they come in and we discuss them as a group, which patients potentially would benefit. We look for patients with flail chest, patients with high pain scores, and patients with very displaced rib fractures. Then we get a 3D reconstruction to really kind of plan out our procedure. Now, if we talk to the patient, we discuss, risks and benefits, how we do it, if this is something they would want to do. If they agree to it, and then
or their family, right?
Or their family, absolutely.
Sometimes they're intubated because we had a patient who repleted and who's intubated out cold.
Right. So we explain to the patient or their family, these are the risks of it, and these are the benefits that could help, your loved one. So when we are into the operating room, we perform video-assisted thoracoscopic surgery or a VATS. A lot of these patients have a concomitant hemothorax, so we want to make sure we drain everything. So our group is very well trained with the VATS procedure, and we all are able to do it. And then when we start the case, we do cryoablation. So we have a representative come in, and then we freeze the nerve bundle that lives underneath the ribs, and it's greater than negative 50 degrees Celsius, and it gives them 4 to 6 weeks of pain relief after the procedure.
That's awesome.
So we freeze levels 3 through 9. And then we start our case. So the benefit of doing the VATS before, again, you get to wash out the hemothorax, you can do the cryoablation, and then you can plan where you're going to make your incision. When we do the actual rib fixation, we make an incision. Sometimes it can be pre-planned. Other times it's when you're in the operating room, you have to decide what's going to be the best for the patient based on their musculature, based on the rib fracture pattern. And based on where anatomically makes the most sense. Because sometimes you're going to be rib plating multiple levels. Sometimes the fracture pattern is staggered. Sometimes you're going to be rib plating the same rib, but there can be a wide gap between 2 rib fractures on the same rib. So we make our incision. We divide all the tissue. We divide the muscle. You can spare the muscle. You don't have to cut through it. And that can help with postoperative pain and can help them, decrease any lack of mobility or lack of function afterwards. And then we use a titanium plate. We can conform it to the rib. And once we do that, then we drill screws into the rib on either side of the fracture line. And we ensure that there's no big spaces or gaps. And we kind of work down the lines. And then after that, we close, all the muscle, all the subcutaneous tissue, and we close the skin.
Very cool.
And we leave big chest tubes usually to make sure everything's drained.
Right.
Most patients, especially in clinic or even afterwards, they want to see what it looks like. And usually the question is, do these stay forever? And they do. And what it really does, it helps build that lattice of where that fracture is, especially if they're very displaced, to allow your body to heal the bone itself. And especially if they're intubated or if they have flail chest, that can help their pulmonary mechanics in the ICU.
Very cool. So they come right to us.
Yep.
And then what are things from an ICU standpoint that we should be looking out for with these patients?
Yeah, absolutely. So a lot of these patients, because they have so many rib fractures or based on their mechanism, they can have pulmonary contusions also. And those usually don't, we say, blossom until 48 hours afterwards. So you can still have a patient with respiratory issues even afterwards. So what we're looking for is we're not trying to over-resuscitate any of our patients. We're making sure that any of the hemothorax has been drained, any pneumothorax that was there has been evacuated, and we're just ensuring that they have the best pulmonary mechanics to allow them to get extubated, to allow them to have better pain when they do get out of the ICU.
That's very cool.
Yeah, it is. So it's neither here nor there, but I I think about rib plating as what if do they feel they feel the plate,
The titanium.
the titanium, and does it hurt, and has anyone ever asked, take this out?
Yeah, so patients usually say not from the plate itself, but if a patient comes in and they have either malunion or non-union, we have patients that still have clicking, popping every time they breathe or move. And those are patients that can benefit from a delayed rib fixation. It's very few and far between that the plates ever need to come out. If they become dislodged, they can, obviously if there's any sort of infection, but usually they stay in there and there's no problems inside there. But, patients are concerned about that am I going to feel this? But usually they don't feel that. Usually they feel the ribs clicking and popping if they don't get plated.
Very cool. So are you guys as a trauma team going to be publishing more, given that you're such a big we are such a big rib plating. I'm taking credit for what you guys do. Such a rib plating hospital.
Yeah, I hope so. I hope to prove, the benefits of it, and then we can start looking at the different patient populations that would benefit, whether it's from, older patient population, whether even sooner rib fixation patients can benefit from it, and really nailing down, because in the literature, it's tough to kind of parse out exactly the non-flail patients that can benefit. So I think we're going to have a large enough cohort, large enough, N number to be able to discern who benefits from it or not.
Yeah, I feel like we have so many patients in the ICU with rib fractures, and it's kind of like our bread and butter, and we go through the same sort of algorithm. We consult the anesthesia pain team, and we just kind of make sure that they're breathing and coughing and mobilizing, and I think this really changes the game in terms of length of stay and just overall morbidity.
What about patients with COPD or?
Yeah, so I think patients with, an underlying respiratory issue, those are going to be patients that are even higher risk for respiratory decompensation if they don't get fixed. Whether it's more of an obstructive issue, I think them not having the ability to breathe better is going to make it difficult for them to either come off a ventilator or get back to their baseline. Some of these patients are requiring oxygen at baseline or, have chronic COPD, and that insult to their lung and their pulmonary mechanics could make it so they won't even get back to where they were before, which might have not been the best. And what you were saying, Katie, about this, our department, we're busiest trauma center in Massachusetts, so I think we do have that patient selection, that patient population to be able to parse out which patients really can benefit from this.
Very cool. That's awesome. And so someone told me that you're on the you're doing the quality stuff for trauma, you're doing the billing stuff. Yeah. How's that going?
Yeah, no, it's going great. And, it's something in medicine that
But what is that? What are you doing with the quality stuff and the billing stuff? Yeah. What are you doing with that?
We got to stay a level 1 trauma center, baby.
Yeah. So, being in medicine, I think it's part of being in medicine, part of being at an academic center, that you want to ensure that what you're doing, you're meeting metrics and the types of procedures, the types of care that you're giving is up to standard and up to par.
Are we?
We are. Yes, we are. Yes.
It's on my watch, absolutely.
Yes, we are. And kind of on the flip side of things, everywhere in medicine is feeling the strain of financial issues. So it's not trying to get paid more. I don't see the money. It's not trying it's trying to ensure that the care that we're giving patients, the work that you guys are doing, that we're doing, the whole team's doing, because it takes a whole trauma center to care for these patients, that we are getting reimbursed. So whether that's, documentation issues, whether that's correct billing, because becoming a surgeon, they didn't really talk to you about that, right? And, being an APP, I don't know if they talk to you guys about, how to properly bill. But once you learn some of the ins and outs of it, getting paid for the work you do is beneficial for the whole, institution.
So we get a billing class.
Yeah. Were you paying attention during it?
Well, yeah, I was.
Oops.
But do you mean the residents don't get a billing class?
So I know that there are some people in the Department of Surgery that do teach them about billing, but as I remember being a new attending, trying to figure it out as I go. And it took a lot of, guessing and checking, if you will, figuring it out, asking partners about how to properly bill. I've had countless meetings with, kind of the billing department about how we can ensure that things are, billed properly, to ensure that we're, trying to get whatever we can financially to keep the institution fiscally sound.
And so you, as a fourth-year trauma attending at this point, you've had a lot of hats. You wear a lot of hats on the regular. You rotate through acute care surgery, trauma in the operating room as like the activation surgeon, the rounding surgeon, the ICU attending, and then, of course, your quality and billing job. What is your favorite?
Yeah, so that's difficult to say. And I think the benefit of being, a trauma and acute care surgeon is you get to wear all those hats, like you said. And one of the reasons you go into it, I think, is you don't have one specific interest, even though I do. So, so I think once you go into this and you get a couple really good trauma saves, I think that is one of those things that can touch you to your core, right? When you said, we see people on their worst day, that's completely accurate, right? Like, have I had to talk to family members, let them know, unfortunately, their grandmother, parent, kid has died? Yes. Do I hold their hand and do I cry with them sometimes? Yeah. I mean, that's part of it. But on the flip side, you also have people that come to you and, give you a big hug and say, thank you for saving their life. And, I've had patients that have, I've seen in clinic, they're crying because they're so grateful and thankful that, not just what I did, but, the rest of the trauma team, you guys, and the whole hospital can, we saved their life. So it's one of those things that it makes you feel that the working the nights, weekends, holidays is worth it. And, when I go home and, I'm tired and my wife goes, how was your day? And I say, oh, I saved a life, right? That's worth it for me. So
yeah. Do you talk to your wife about some of the harder days?
Yeah, absolutely. And I think that's part of medicine. And, I would encourage anybody in medicine to be able to talk to, if it's not their partner, to somebody maybe in the field. They understand, I'm blessed and lucky enough that my wife is a nurse. So she understands, when I have a bad day and she can kind of tell, we can talk about it. Sometimes you have to compartmentalize in the moment, right? So, it's controlled. Yeah. It's controlled chaos sometimes in the trauma bay, or when you're in an operating room. But being able to compartmentalize in that moment and focus on the patient and realizing that it's a privilege to be able to do what we do and then thinking about it. And, my group is really great. If somebody has a bad day, we can talk to them and say, this case, did I do things right? Because I think if you're in medicine, you always strive for perfection, and you can do things perfectly, and the outcome can still be poor. But that's what we strive for. That's what everybody strives for. But knowing that if you did everything appropriately, did everything right, and the outcome was still poor, and you have somebody that you trust, care about, even love, telling you, yes, I would have done the same thing. It's been very helpful for me.
Oh, yeah.
I know we talked about the schedule already, but I noticed that you guys do a lot of 24-hour shifts.
Yeah. So
every week or?
Sometimes usually on the weekends, you'll do 24-hour calls Saturday or Sunday. It's not all, running around the entire time. Sometimes it can be, but sometimes there is some downtime. But being able to, get a little downtime, and then when the pager does go off, being able to flip into that mode and realize, this is what, you're called to do. This is, the patient needs you, right? The team needs you. And putting them, maybe ahead of you being tired is what we do. And there can be some adrenaline in there that can get you through. And then maybe you just need, chug some water afterwards and take a little rest. But, that's just kind of part of it. And what you can do in your mind, and realizing that even if you're tired, you can still do your job really well, has been something that I've learned as a newer attending. And what your body can handle is a lot more than what you think. And, doing jujitsu has taught me that as well, right? When you're actually being, choked out, right? It's very different than saying, oh, well, I'm just a little bit tired. So realizing the limits of your body and realizing, also the emotional strain that it can have on you, but being able to kind of, breathe through it and think about it introspectively has been very helpful for me.
How did you start getting into jiu-jitsu?
Yeah, so my brother, he's trained for a few years and he competes back home. And it's kind of one of those things that I've always thought about doing. And my wife signed me up for a class and said, you're going to go. So I was like, okay, fine. So I started going and I met, wonderful people, Frankie Passos at, Daniel Gracie Academy has been wonderful. There's some people that even work at the hospital here and, they call me Doc there. And they know that I'm not there to go too hard or anything. And so they'll stop even before,
They're like, oh,
I want them to stop.
We can't crack my ribs because the plating guy is here.
Exactly. And yeah. So it's been really great to do that. And, my wife asked me, how was class? And I was like, oh, I just was beaten up for the last hour. And it's humbling. Coming from being, a trauma surgeon.
Top dog.
I wouldn't say that, but yeah, coming from being a trauma surgeon and going in there as a white belt and, these people, younger than me they've been doing it less than me and, being thrown around and it's a new skill set and it's been using a different part of my brain and good for my body too.
Yeah.
When it doesn't
gotta
hurt
protect
so
the
much.
hands, gotta protect the hands.
Protect these.
That's true. What are you doing to protect your hands?
Not a lot of hand issues that happen in it. Thankfully, like I said, they kind of look out for me too.
You have to strike, don't you?
No striking. Yeah, no. It's about it's just submissions and things like that. But it's been wonderful, I think, to be able to decompress when you do have, maybe a bad case or a bad day. It uses a different part of your body, and being up for 24 hours can be really difficult. But rolling for an hour can be, really difficult and
its own way, yeah.
Yeah,
it's also just like coming out of the hospital, you're like, whoa, is that real life? Like, of course it is, but it feels like this weird sort of thing that's otherworldly, and then you come back to kind of your own life, and you're like, oh, we're just having a good time on the mat.
Yeah.
Yeah.
So top 1, 2, 3 things that you do when you've had a tough day.
Yeah, so probably number 1 is my kid. So regardless of who I am in the hospital, what I've done, what operation, what I've done in like the ICU, when I get home, I'm still just dada, right? So regardless of what I have to do in the hospital, when I get home, it's still, making him dinner, right? Getting him to bed, giving him a bath. And that kind of can flip your mindset that I'm so lucky to have him and the joy that he brings me and to our family, right? So it can create a whole different sense of purpose outside of the hospital. So that's been wonderful for me. In doing this job and knowing that, I think it would be something he'll be proud of is wonderful as well. Having a wife that understands has been, I couldn't think of something better for her just to be able to talk, or if I don't want to talk, right? Just hanging out in the silence is fine. And then getting outside, I think it's really good. The hospital, you don't know what time it is. Sometimes it could be 2 a.m. or 2 p.m. It all kind of looks the same under the fluorescent lights. So getting outside, and even if it's gray and cold and negative numbers in New England, has been really helpful for me. So yeah, those are the kind of things that can keep me well-rounded and keep perspective. And what I tell the trainees, perspective is key. Right, you're doing this. You're learning a craft. You're learning, you're learning the skills to save lives. But keeping perspective, right? Keeping perspective that this is important, right? This is what you're going to do with your life. You are going to save lives. You are going to change lives. But realizing that you still have a family, you still have a partner, right? And giving them the time that they deserve is important as well.
True, very true.
Very cool.
What's your anthem song?
My anthem song. I was thinking about this, actually. So I'm going to go a little old school. So Thunder Road by Bruce Springsteen. Yeah, I grew up with a lot of Bruce Springsteen in the household, and it's kind of one of those songs that can keep you going, I think. Yeah.
That's awesome. Well, thank you so much for talking to us.
Absolutely. Yeah, we really appreciate it.
Yes.
Thank you guys very much for having me. And again, thank you guys for taking care of patients with us.
Yeah,
It's you too.
It's our honor.
Thank you very much.
Yeah.
I appreciate it.
Yeah.
Like and subscribe.
Thank you for joining us on another episode of the Crit Chat podcast.
It's critical chat, Shayla.
Remember, you can watch the podcast video on YouTube or listen to us on Spotify, Apple Music, CastBox, or Amazon Music.
Everywhere.